Then you can do this one, I go ahead.
Okay, thank you.
Okay, I think we're ready to start our workshop, and thank you for your flexibility in making this last-minute change from being in the sanctuary, which is really, really, really cold, to the fireside room, which is just really cold. And so we envy you who are joining us online, and but we are hopefully we'll warm the room up here as we get going. So I want to introduce some folks here from the Southern Maine Hospice of Southern Maine, and so we have Kim Crable,
Yeah, good job.
and this is Kelly Blanchett. Is that right?
Yeah.
And
That's a travel one.
what's that?
Scarborough, yes.
From Scarborough, yes.
I thought so.
Yes.
I visit my dad there.
So we're going to be talking about hospice care, and then we're going to be talking some about grief and kind of what services that you all provide.
Yes,
So
wonderful.
welcome. Thank you so much.
Thank you. Can you guys hear us okay if we sit down, or should we stand up?
That's great.
No, you're fine. Okay, we're fine. Okay, thank you.
Tell us to speak up if you need us to.
So we did have a presentation that was slides that seemed to make more sense if it was in the actual church, but we're just going to have a conversation, and you guys can ask questions, and I'm kind of sure whenever we talk to local groups that people are fairly familiar with hospice. And how many people in here are familiar with hospice care? Yeah, good job, everyone. And how many people have a positive impression of hospice care?
Wow.
The homemade Brandit.
The what?
The homemade Brandit.
Okay.
Did you know that Brandit is homemade?
I did not know that.
Well, I saw it and it was pretty when I visit my dad. And the fundraiser for the Ronald McDonald House, somebody made the Brandit and donated it to the health care.
Wow.
Wow. They're like quilts.
That's great. So we do have a lot of community support, as you point out. And it's good, I don't feel like this has to be a big, long education session, since you already know about hospice and you already have positive feelings about hospice. So I'll tell you a little bit about Hospice of Southern Maine, and I'm kind of assuming, how many people are familiar with Hospice of Southern Maine or have had someone on service there? Okay, so most of you. Okay, wonderful. So Hospice of Southern Maine actually
Just heard about you.
Oh, you did?
My dad was dying at the hospital and he wanted to go to hospice. I expect that he didn't want to go there. He remember what happened to us. He can't remember.
So we are a big resource for the community. This year in 2024 will be our 20th year of service. Hospice has been in the United States for 50 years. The first hospice was started in Connecticut. And in 2020, the Robert Wood Johnson Foundation did a study of hospice care throughout the United States and found that Maine tied for last of the states in the number of people eligible for hospice that actually used it.
You have to fight for it.
Well, we were 49th, tied for last with Alaska. And you can kind of imagine with Alaska why there's an issue. It's very spread out, hard to service people there. But there was a group of people in Maine who came together and said, we can do better than this. So Hospice of Southern Maine sprung out of that action, and this year last year is the last year for which we have detailed stats, and Maine was 9th in the nation in terms. So we've done a huge job of working with people and educating them, and that's kind of my role at Hospice of Southern Maine. I have one other. I work in Cumberland County. I've got a cohort who works in York County. And we do a lot of community education to make sure that people are aware of what hospice does and when it's valuable. And the only thing I'm kind of sad that I can't show you or won't be showing you just because the presentation is longer than we have time for, is a really great conversation between Atul Gawande, who is a surgeon at Brigham and Women's and kind of a world famous author. He wrote the book Being Mortal that some of you might be familiar with. And he has a conversation in this one video. Maybe I'll send you the link afterwards and you can share it. But he has a conversation this is a person who, you know, his father was on hospice care. He is a big proponent of hospice care. And he had a patient who was 9 months pregnant, who was diagnosed with stage 4 cancer. And they wanted, you know, the wife and the husband just had this tremendous kernel of hope. And they had so much hope, even though Dr. Gwande knew that there is no recovery from stage 4 lung cancer. They basically, their hope convinced him that the treatment, they should go forward with treatment as opposed to go on hospice. And this conversation is between Dr. Gwande and the husband after the wife has passed, with them both saying, we both made grave errors. Like, we shouldn't have pushed her for treatment. You know, the husband's hope should have been formed into a little more realistic, you know, a little more realism to it. And Dr. Gwande's like, yeah, I basically could have lost my license because I was suggesting that you do something that I knew wasn't going to happen. So I like to show people that just because we talk about hospice, and, you know, my dad passed on hospice last year, but it's not an easy decision. And I like to point that out. It's not like we come here and we say, oh, go on hospice. We know it's different for everyone. It's a difficult decision. And even for Dr. Gwande, who knew what would serve the patient better and give her more good days, which is what we look for, he even said, you know, go the route of treatment. So, so hospice care is basically, and I feel like I'm telling you and you already know, it's for when you've decided that you would rather have compassionate comfort care rather than continue with treatments if there is another treatment. Sometimes there's no, you know, people have exhausted the treatments and hospice is all that's left. We hope that people come to the realization a little bit earlier that maybe hospice can provide them with more good days and more support as opposed to being in the hospital and undergoing treatments that are going to sometimes be worse than any cure. So this is, I'm going to leave you with some of these. This is what we use to educate the community. Whenever anyone comes on hospice, we leave them with one of these, because when we go and visit people, typically all their, you know, their family and friends aren't gathered around, and there is so much misinformation about hospice. But this is basically a booklet we put together on Hospice of Southern Maine, which introduces our CEO and Dr. Moreno, who's our medical director, who's part of the palliative care team at Maine Med. And then we talk about eligibility and services. And basically you're eligible for hospice when 2 physicians agree that your prognosis is 6 months or less. And that scares people because they say, oh, 6 months or less, that's, you know, I don't want to do that. But we have people, you know, we have a lot of people, unfortunately, who come to us directly from the hospital and only spend a week or less with us. You know, we have people who've been with us for 3 or 4 years. So it's a wide range of people who are on hospice. You're not, if it's recommended you go on hospice, you're not always going to be not with us any longer. You're not going to die within 6 months always. Sometimes you will. I've met a lot of people who went on hospice, and hospice is just, you know, they strip away a lot of the medications that you've been taking for cure, you know, for cure for the disease, and leave you with the ones like heart medication and things that you can't live without, and also, you know, maybe some pain relief if you're at that point or whatever. And people start feeling better because all these medications and all the counterindications are gone. So people can get, depending on what meds they were on, this hospice bump. And they can, you may know some people who say they graduated from hospice, and they're at the point that Medicare says, no, you're no longer sick enough to be on hospice care. So there are all these ranges of what hospice means, and that's what, you know, I want people to understand, that when people say hospice, it doesn't mean it's imminent death. It means that the patient has decided they want to be comfortable and no longer seek curative. And 2 physicians have said, to the best of their knowledge, because no one can predict, that 6 months is what they would think that, you know, is your lifespan at that point. But it is very different for everyone. Hospice of Southern Maine hospice is all we do. There are probably 5 or 6 hospices that service this local area, Cumberland, York counties. We're the only one that's solely dedicated to hospice. We're experts in hospice. Our
Home.
Yes, most of our patients are on home hospice. Like 98% of our patients are at home, and that's wherever they call home. It's, you know, a nursing home, their actual home. A couple years ago, we won the Preble Street Award for taking care of people who were homeless, who, you know, the home was outside, you know, on the sidewalk, basically. So wherever they're living, whether it's in a car or in a mansion, we will take care of them. But we're the only not-for-profit hospice that's only hospice care, and we do have a lot of our professionals who have certifications in hospice and palliative care, like they're drawn to this work. You don't go into hospice to make money. You go into it because you're an empath who wants to make people's lives better. And we do have what we call an expanded philosophy of care, and Daryl Katie, who's our CEO, has this great saying. She's like, why wouldn't we do that? So when a nurse comes to her and says, I would like us to pay for something that's outside of the Medicare benefit, because Medicare will pay for specific things, but if there's things outside that we feel will benefit the patient, whether it's maybe some dialysis to get them through to a date of a wedding or a baby's birth or something like that in their family, hospice benefits through Medicare and insurances won't pay for that, but we have additional monies that we can pay for that. So we call it our expanded philosophy of care. And Daryl Katie is great because she's like, why wouldn't we do that? You know, and some hospice patients need some medications that are quite expensive to improve their quality of life, and we try to do everything that we can to make that happen. This is really one of my favorite parts of this brochure because it shows the patient and the family, and it shows what we call the interdisciplinary care team, which, you know, goodbye.
Bye. Hi, Marina. Hi, Melissa.
But this is the support team that once people come on hospice is available to them. And it starts with, over here is the physicians, and this is our medical director and any of the patient's physicians that talk about what the patient's plan of care is and how to manage their stay on hospice to meet any goals they might have and just to make them as comfortable as possible. We have nurse practitioners, and primarily most of our nurse practitioners work at Gosnell Memorial Hospice House, which you probably are familiar with. You know, when I said 98% of our patients are taken care of at home, the other 2% are taken care of at Gosnell Memorial Hospice House, which is both an inpatient acute care facility for people who have pain and symptoms that can't be managed at home. Maybe they need IV, something that we can't set up at home, or they just don't have the support at home at that point. So we can use it. We use Gosnell for that, as well as for respite care, which every Medicare does certification time frames, and you don't really need to know that, except for they do have every time frame that you're certified for as a hospice patient. You can spend 5 days at Gosnell and give your caretaker a break. So there are lots of elderly families, you know, a husband and a wife, that one is taking care of the other, and it's exhausting work sometimes. So they need a break. They need to sleep maybe, or reconnect, or go on a trip, or just do something. So Gosnell also provides that respite care when people, it's not for pain and symptom, it's just to give the caregiver a break, and Medicare approves that and pays for it, which is really nice. So the nurse practitioners primarily work at Gosnell, but they also work with our home team. And the home team kind of starts here. The registered nurses, everyone gets a care manager, case manager, who meets with the patient and, talks with them about where they are in terms of medically, and also figures out what, if they have any goals, what their goals might be. And I know it kind of sounds crazy when you talk about goals at end of life, but we have a lot of people who have, it is some event that they want to get to, or, we had, I think this because we had a contractor who was a poet as well, and he always wanted to write poetry, and it gave him, with our support, it gave him a chance to write poetry, and we ended up compiling it. He let us compile it in this little publication, and at Gosnell House, we give one of these to every patient, and there's one in every room, and it's just really it's a lovely thing that he could do and that we could help him, and it's a visible one that I like to share, but there's so many that aren't visible because it might have been an event or whatever it is, and some people don't have any goals, which is fine. You don't have to have goals. You just have to want to be comfortable, and that's what the nurse will work with you on. And based on what those goals or what you've decided, we bring in the rest of the team, which is a hospice aide, which can help provide companionship as well as personal care, a social worker as well to take care of emotional support, to help you with that, to help with difficult family conversations, and to connect people to resources that they might not know are available in the community that would help them out. You know, our nurses are always, or our social workers are always working with people on funeral planning, you know, connecting them to resources or VA benefits or home care that they may need that we can help them get established. So the social worker kind of takes a look around and figures out what kind of support they can help with. We have chaplains that are non-denominational. They can help with spiritual support, even if people have a practice already, a spiritual practice, they can still come in and just be a listening ear and help with conversations. And we have so many great chaplains who talk about people who, you know, when people have these deathbed reveals, the chaplains get a lot of that sometimes because people, it's a secret that they have that they want to share with someone. So that's takes a huge burden off people's minds. So it's a group of fabulous people. And then grief support, which Kelly will talk about after I'm done running you through here. And we also have volunteers. You know, Hospice of Southern Maine right now, we have 150 employees and we have 150 volunteers. So, and right now we've got about 250 patients that are on care with us. So patients have to have a nurse case manager. They don't have to have the rest of the team, but we highly encourage it because they add so much value to what hospice care is all about. It's not just expert medical care, it's the psychosocial care that the rest of the team brings in that really kind of supports people and provides that compassionate care, but they only have to have the registered nurse. And there are few people who do that or have the registered nurse and a social worker. So I want you to know as well, if we have some people who are private and they don't want a hospice aide coming in and doing anything or whatever, we're flexible based on what that patient's needs are. And our volunteers just do fantastic things from, you know, cooking a meal to taking someone to a doctor's appointment to a whole bunch of things, like whatever anyone needs. One of my friends is a volunteer and he loves to play games and cards. And so he'll just sit there and play games with people, which is great. And we've got volunteers also who run programs like Paw Prints, which is therapy dogs that they'll take into Gosnell as well as people's homes. We've got Reiki energy healers. We've got people who come in and play music. So just a lot of different things. So I do have some volunteer brochures here. So if anyone might be interested in talking with our group about what that looks like. So hospice care at home, I talked to you a little bit about this as well as Gosnell. And we talk about all hospices are the same, or are they? There are a lot of hospices, like I said, in the area. You have a lot of choices. Our expanded philosophy of care, as well as the fact, sometimes when people think nonprofit, they think, oh, low budget, you probably can't afford different things. We get so many donations, and we do fundraising in the community. We have a big fund to support people who are uninsured, underinsured, whatever we can do to help. So every year we spend about $300,000 covering costs for people who couldn't afford it otherwise, because we don't believe that it should only be available for people who have insurance. That's not a philosophy of all the hospices in the area. And there's some other things. I just want you to know that even though hospice care provides for that interdisciplinary team that I showed you, it looks different at different hospices, and the amount of care you might get from different hospices is a little bit different. Medicare does have a website called Care Compare, and you can go into your area, put your area code in or your zip code in, and then search hospices, and it will show you some of the results from primary caregiver surveys that Medicare does after people pass, and we're typically at or above benchmarks. And last year we were one of only 60 hospices in the country, which there are over 5,000 hospices in the United States, to get Hospice Honors Elite, which means that we, based on these primary caregiver surveys, we surpassed in every category that they asked us, which we're really proud of, because that is not easy with such a diverse group of people providing care in a huge area. This just has some nice quotes that people have said, and one of one of the things that people say to us frequently is like, I didn't even know that hospice existed, and I wish I called them earlier. So that's why we get out and do education, just so people know that it's an option. Because sometimes even if physicians don't really or aren't ready to refer, like Dr. Guame wasn't, people can self-refer. Like if you know, I referred my dad. Like you can call up and say, you know, obviously with their permission. You don't want to just send us to their house.
We kind of frown upon.
You don't want to show up. But anyone can refer themselves or someone else. And it's important to know that. And all hospices don't take self-referrals. That is an important thing we do. Because it does take a lot more work. Because if, you know, say I'm someone who didn't have a primary care physician, which there are a lot of people in the community who don't, you know, have any kind of health care. If they refer themselves, then we've got to figure out where they are and if they would be eligible for hospice. Because even if we're going to pay for that, we want to know that they meet those criteria. So anyone can refer. It's just important to know that and to advocate for yourself or others when you're at that point. You don't have to wait for a physician to say, I think you should think about hospice. And we'll come out and do an assessment. So just keep that in mind. This is our service territory. It's basically York and Cumberland. And let me just show you what these are, and then I'll let Kelly talk. You can talk about bereavement. This is our opportunities to volunteer. And this is, during COVID, like one of the only good things that came out of COVID for us was we weren't able to get out and do community education like this, so we started doing webinars, and we filmed all of them, and we asked experts within our organization and outside our organization, like this lovely lady who wrote this book called Gone From My Sight, which is, how many people have ever seen this? Okay.
I think the poem on the back.
It's not on the back in this one, but it is in here.
I ended my mom's funeral with that.
Oh, you did?
Yeah.
So the woman who wrote this was a hospice nurse in the 80s, and when she was sitting bedside with people, people would say, well, what's next for my loved one? And so she'd write down, this is what you're going to see, this is what you're going to see. And she kept doing it. So finally she wrote it down and took it to her manager and said, would you please publish this? So it would save me some time, bedside, and I could just go through it. And he said, no, why don't you? So she did. And now she's sold 35 million of these worldwide. Wow. We provide it to everyone, and it basically takes people from 3 months down to when they're passing, because hospice care is a different thing when your body is shutting down as opposed to curative care. It's different than what you've always seen. So it's really, like for my mom, this was invaluable. Like she would come up and say, I think he's here. And it's something that if you normally saw that, you might call 911. And hospice is there, you want to be at home. We ask for people to call us first because it might be something that's totally normal and the caregiver just needs more education. But it might be something that they need to go to the hospital, in which case we will say, we'll call the ambulance. But this woman, we've interviewed her twice on here, and she's just fantastic. So we just have a lot of resources here about hospice, about advanced care planning, just, some about Hospice of Southern Maine. So we do these, kind of usually once a month or once every quarter, depending on what topics we have. So if anyone's interested in signing up for that, you can take one of these. And with that, I'm going to turn it over to Kelly to talk. Well, and then we can take questions at the end for everything.
Sure.
Okay.
So my role at Hospice of Southern Maine is to run the bereavement department, and I am a grief counselor providing direct services to patients' families. And I'm here to talk a little bit about grief. I'll try to keep it brief. I can get on a soapbox and run on and on and on, so please just stop me.
I'll nudge you.
Just throw something. At Hospice of Southern Maine, our grief support services are free of charge for everybody. Families and friends, and family is a very broad term that we use, so family includes anybody the patient includes as family, whether or not they're actually related to them or not. Family and friends are entitled to up to 13 months of bereavement services after their loved one dies. And this can be shown in a couple of different ways. One being every family gets a phone call from us Depending on their specific needs, that might be a week or two after their person dies, or it might be about a month out, just to check in and see how they're doing. And everybody receives mailings for 13 months that offer information on grief and information on our services, as well as some resources. Beyond that, people have a choice if they'd like to try grief counseling, which is not therapy. It's not meant to diagnose or treat anything, because grief is normal. But it does give a supportive space to talk about grief, learn about grief, and process the loss. Lastly, we offer support groups that meet for 6 to 8 weeks, depending on the time of year. And these groups are meant to bring people together with a common experience where you can learn from each other and learn about grief and share what maybe has worked for you or what has been a struggle for you, and get input from others. And these services are open to everybody in the community as well. So we are very lucky to be able to offer our groups and our individual grief counseling to people who had a loss not necessarily through Hospice of Southern Maine. So, yeah. And we do this because grief is a normal human experience. Grief is a very small word that represents so much. It encompasses all of the feelings and experiences that can happen after somebody dies. It's a human experience. I always say that the older I get and the more I see, the more I'm seeing it's a non-human experience too. I'm just not qualified to speak about animals and their grief. But it does impact every single human being, from infants through adults. Grief looks different depending on developmental stage. I won't get into all of that today, but we do have an Ask the Experts on Grief that kind of breaks that down a little bit more. Grief has a lot of effects. People are very familiar with the emotional effects, the sadness, the yearning, missing somebody, sometimes anger and guilt, regret, all normal. But grief actually impacts every person on every level. So grief causes cognitive effects. It's very normal when you're grieving to be forgetful, to have trouble focusing, maybe be slower at processing. Grief causes physical effects. A lot of people carry grief and muscle tension, maybe neck aches or back aches. GI issues are really common too, whether that's stomach aches, nausea, anything really in the body. Grief can settle anywhere, cause aches and pains, can cause clumsiness. Grief can even make you immunocompromised for a little while. These are things that people come into our office, they're like, you're going to think I'm losing my mind. I'm like, no, this is all normal. Grief causes a lot of cognitive and spiritual effects too, like questioning. It's normal to question beliefs, normal to question identity. These are all well within the scope of grief, and I could stand here for an hour and name things, and it wouldn't even begin to encompass all of them. So grief is very widespread. There's no universal grief path. There's no nice little checklist to say, okay, I did this, I should be getting better, right? Unfortunately, it doesn't work that way. Grief is pretty wild and chaotic, messy, all over the place. It's normal to have good moments and what people refer to as bad moments, although I call them normal moments. At Hospice of Southern Maine, we really like one particular model of grief called the dual process theory.
Say it again, please.
The dual process theory. And within that, it's normal to swing between loss-oriented behaviors and restoration-oriented behaviors, with loss-oriented behaviors being things that look like grief. Active grieving, crying, missing the person, feeling all of the feelings that come with grief. And then restoration-oriented activities and behaviors would be things that are kind of reintegrating into life. Maybe it's something that is distractive. Maybe you're seeking distraction, or you're just getting caught up in day-to-day life. And it's normal to go back and forth and back and forth. We also use our hands a lot to talk about grief, so sorry. But it's normal to go back and forth within a day, within a week. Sometimes people come in and they say, I don't know what happened. I thought I was better. I had a whole series of really good days where I was really living my life, and then I got sidelined, and now I can't function because of my grief. And that's completely normal. It's normal to have ups and downs. People often describe grief as waves, that it kind of comes in and settles. I think in the beginning it can be like tsunami after tsunami, and then eventually gets to littler waves. A lot of people are familiar with Elizabeth Kubler-Ross and what are known as the 5 stages of grief.
Yep.
And those were actually never meant to be about grief. So those stages came from a study that she did on people who were dying. And they were found to be common things that people experienced when they knew that their end of life was coming. Somehow that got taken into grief, but we know there's no stages to progress through. I think our brains crave order, and that's why we want something. We want stages. We want that checklist. But we don't have that. And that can be really, really hard. I think that there's a general discomfort with grief, for grief within ourselves and grief within other people. Trying to make sure I talk about what I need to talk about. Sorry. Within hospice, we often talk about anticipatory grief. Anticipatory grief starts before somebody dies. And it can start as early as a diagnosis. It can start when a loss is expected, or it could start when a loss is feared, when it could happen, before it's even something that will happen. There's a lot of loss on the way to a death. Oftentimes there's loss of skills and functioning, loss of capabilities. There may be financial losses along the way as well, when there's enormous medical bills, or maybe a change in status in a family. Maybe somebody has to stop working to be a caregiver. All of these things can add to that anticipatory grief. And unfortunately, anticipatory grief is not a substitute for grief that happens after a loss. So you can be grieving the whole time and then still be hit with really intense grief after your person dies. Within anticipatory grief, sometimes we also talk about ambiguous grief, and that's when there's uncertainty. That can come with things like substance use. It can come with military deployment, where you know that there's a risk of loss, or there even is a loss if there's that separation. We also talk about disenfranchised grief, and that's grief that's not supported. It's grief that's not acknowledged either by yourself or your community or society as a whole. And that often comes with stigmatized losses like suicide, substance use, drunk driving. It also happens with other kinds of losses that may or may not be related to death. It's pretty common to feel unsupported with miscarriage, stillbirth, and infertility. Adoption brings a lot of grief as well. Oftentimes we have families where there's an estranged family member, and you may think that the estranged family member won't grieve as much, but they often have more complicated grief. They often experience that disenfranchised grief of feeling like they don't have the right to grieve, which can come with more shame, more anger, and more isolation because it's not supported. I do want to address now that we had a mass tragedy event within the state very recently. And I think that as a whole, we're a small state, right? We're a state that is essentially a small town. And a community that's grieving as a whole, whether or not you lost somebody you knew. It's normal now to be grieving the loss of the lives that were lost. It's normal to grieve the loss of our safety, our security, our community. All these can happen when there's a mass casualty event, when there's violence, war, and this brought it home for us. So just wanted to put that out there. And we do have some reminders of what's normal to be experiencing in this aftermath, whether or not you knew any of the victims. I'm talking a lot, I'm sorry. Almost done. The most common question we get in the bereavement department is, how can I fix this? How can I make myself better? And nobody likes my answer because it's, well, you can't. It takes a lot of time and a lot of patience and a lot of compassion for yourself. And that's hard. It's really hard to sit with these uncomfortable feelings. But the most important thing is to know that they are normal to experience and that it's really, really important to have some compassion for yourself and how you're feeling. One of my bereavement clients told me that she felt like her soul was injured. And I thought that was a perfect analogy. If you have a broken leg or an illness, you'll tend to that. You will give it the attention it needs, hopefully. Maybe have some patience for yourself, rest. And when your soul is injured, you need that too. You need that rest. You need that attention to yourself. You need comfort. It's important to be with people who understand your grief if possible, or at least your boundaries around your grief. Your grief is your grief, and if you want to share it with somebody, that's your decision. If you don't want to share it with somebody, that's okay too. It's important to consider coping mechanisms. What has helped you in times of stress or crisis in the past? For some people, that might be surrounding themselves with people. For other people, it might be withdrawing a bit. For some people, getting outside, maybe staring at the ocean or doing physical exercise can be helpful. For other people, creating is important, maybe turning feelings into art. And know that it's okay to have days when it feels like you just can't. If you get up and get out of bed, take a shower and brush your teeth, that's a success. That's okay. We also often are asked how to help somebody else who's grieving, which is really hard too. It's not easy to sit with pain. And what I cannot stress enough for people is don't try to fix them. Give them their space for their grief. Be with them, but learn to be in silence. It's okay to not have the right thing to say, because there's nothing that brings their person back. There's nothing that fixes it for them. It is important to say the name of the person who died. Talk about them. Ask questions about them. Not about how they died, but who were they? What was important to them? Tell me a story about them. Or maybe you have a story you can share about them. Don't be afraid to say their name. A lot of people are afraid to say the name of the person who died. And a lot of people, when they're in grief, they want to hear that. They want to hear about their person. They want to talk about their person. It won't make them more sad. I always put a little warning out there, too, about platitudes and euphemisms and the at least statements. I think that a lot of times we don't know what to say, and we say something that we think might be comforting, but it might not hit the grieving person the same way. So you always just want to be careful with those at least statements. Oh, at least you had them for a long time. At least you have other children. Those just invalidate their grief that they're experiencing, and they're not supportive. Statements like, at least the suffering is over, or God needed him more, may be comforting to one person, and another person may be struggling with their relationship with God at that time, because it's normal to have some anger or feel confusion about that. So statements like that can just be a little troublesome because you don't know how they'll be received. So sometimes just saying, I'm here. I'm here to sit with you in this is what's helpful. One other note, so I have a whole presentation on grief in children because my previous career was working entirely with children and families in crisis. And if you tell a child that death means somebody went to sleep forever, that child won't sleep again for the next 10 years, and neither will you. Just a little warning about that. Because that's a pretty common one that we hear. And that said, I will add that children experience grief differently based on their developmental stage, not their chronological age, but their developmental stage. And they do have different needs within grief, and it's normal for kids to re-grieve as they go through developmental stages. So a child who experiences a significant loss as a preschooler will re-grieve as a teenager, as they're processing differently, they have new information, and their brain is thinking differently. Also important to know that people who are neurodivergent thinkers, people on the autism spectrum, people with ADHD, and there are other things, sensory integration disorder, that fit under the neurodivergent umbrella, they also tend to process a little bit differently, and that does not mean that they don't grieve. Even infants grieve. It just looks a little bit different. Oh, and the last thing was, before, what I was talking about before. Keep checking in with grieving people. It's normal for, in the immediate aftermath of a death, people to be around. People are checking in, people are dropping off food. But that happens during the very beginning of grief, when there's a layer of shock. Even when you expect a death to be coming, there can be some shock when it happens. And when that shock wears off, maybe it's a couple weeks down the road or a couple months down the road, that's when the full intensity of feeling set in. And that's when people need people more. So keep checking in. So 6 weeks, 3 months, make that call. If you're thinking about them, give them a call. Stop in. Maybe call first. But let people know that you're thinking of them at that point. We do have some information here. We have some book lists, some grief support books, as well as resources within the community. Sometimes grief is more than basic normal grief. Sometimes grief becomes something called prolonged grief disorder, which involves a basic inability to function for a very long period of time, among other things. Not to say that grief doesn't last a long time. It's normal for you to grieve 6 months after a loss, a year after a loss, 2 years after a loss. Grief lasts. But there are times when grief needs a little bit more help. Somebody may have traumatic grief. Somebody may be battling depression alongside grief. So there are some resources here for the main crisis line, as well as how to find a therapist, which I will acknowledge is very, very difficult these days, but there is a link here to find people who are taking new clients at this time, as well as some websites with some information about grief. That's what I have.
That was fantastic.
Thank you.
Can open up to questions now?
Could you clarify a little bit more about making choices about hospice care? Like if someone is under VA, for instance, you mentioned VA, and the VA says, we're going to refer them for hospice. I didn't realize I had choices.
You do.
Did I
yeah,
have choices then?
A lot of people don't realize that, and there is something as well. If there's some like nursing homes that have a preference for a hospice, maybe for whatever reason. But if someone's family, maybe, or the person, sometimes people in a nursing home can't really make that decision for themselves. But if people aren't happy with the hospice service they're getting, they can revoke that and choose another hospice. So you have choice. And if you come on hospice, or someone comes on hospice, and they decide they don't want to be on hospice, it's not meeting their needs for whatever reason, they can revoke. It's just one form they fill, and that's it. We don't have people do that very often, but it's your choice, so they should give you a choice.
Kind of a related question is, how does one choose between in-home hospice care versus a facility? Are there cost differences? Are there advantages to each?
Hospice care is the same group of services regardless of where you are. So if you're at home, you'll have that team. If you're in a nursing home, you'll have that team. So it's based on what other care you need around that. Because if people can't, like we have people, there are some hospices who won't take people who don't have a primary caregiver, because that's who we educate, that's who's actually doing, hospice drops in, once a day usually, and is there, at a certain stage of someone's illness, is there for 45 minutes or an hour. It's not round the clock coverage. So depending on the health of the person, you might need someone like my dad. If my family wasn't home, my mom was with us, he wouldn't have been able to navigate his way to the bathroom or anything. If we weren't there, he would have had to have had round-the-clock care either at home or in a facility. So based on the other needs, then people would move into a facility, but that doesn't interfere with them having the hospice benefit. So they can still have the hospice benefit and live in a nursing home. So does that answer your question? Or
And is there a difference between receiving hospice in a nursing home versus a facility that is just for hospice?
Well, I mean, there is. In our facility, you can only be there if you're what we call general inpatient, which means that your pain and symptom can't be handled at home. So it's kind of for the typical stay at Gosnell is about 5 days, because people at that point their body is going through transition and they will die shortly. But in a nursing home, people can be there for a long time. If they have dementia or other things, they can be there for a very long time. So Gosnell is really for that short term or for the respite care. It's not for people to go there and spend a month. Although in some cases, if people don't have anyone else and they can't afford or they can't get into, like during COVID, people couldn't get into a nursing home in some cases, we would have people stay there on a longer term basis, but that's typically not what those are for. And there are 4 hospice houses in Maine. We service this area, and they're all run by nonprofits. To give you an idea, there are for-profit hospices, which kind of still blows my mind that they're for-profit hospices because it's paid for by Medicare, Maine Care, other insurances, and it's not a big moneymaker if you're doing it right. You're providing a lot of care by highly skilled people who are fairly expensive in the healthcare world. So hospice houses are not a winning, you're not making money on those, you're spending money on those. And that's one of my other differences, that I kind of have an issue with for-profit hospices, because a lot of them will refer to a Gosnell house, but they don't have the ongoing expense of keeping that real stellar level of care in the community. And that's what we believe in, is supporting the whole community right through to the end. And we do have another program that this is a little bit offshoot of that. Like if someone is referred and they don't qualify based on the insurance, which is usually Medicare, 65 and over, but if they don't qualify, but we feel like, well, maybe they're within 12 months, maybe the physician or whomever referred them a little bit earlier, we do have a program called Care and Comfort that we will offer a volunteer and a social worker and a chaplain, and maybe they can talk to a nurse, like not constantly, it's not medical care, but we do provide a little bit of care, and it's free. And that those people can kind of keep an eye on them, so when they do qualify for hospice, they can get the whole team to come in earlier than if you're just making a guess at it yourself. So that's a nice, I said all we do is hospice. We do have that one other program, but it's not a billable program. It's just a free program for the community. And we do typically have like 20, 25 people on that, and a lot of them do convert to hospice. And it's great because we have eyes on them, so we can get them into hospice care earlier, which is good.
Good question.
Yeah.
I have a neighbor who just recently started home hospice this past weekend. I'm going to visit today. Is there anything I should avoid or know or?
Oh boy, I don't think so, because they've just made the decision that they want to be comfortable, and that's what it is instead of being in the hospital, being at home where your friends can drop by and have a cup of tea, so that's perfect. And just see, how you can support them if they're going to be at home, because it can be lonely to be at home. Like, people are busy and they might think, oh, you're sick, I don't want to come by, but I would just say, hey, what works for you, and how can I help you? But that's great. I'm happy to hear that. That's great.
And I think just being there will be helpful.
Yeah. That's what we talked about in the sermon today.
Oh, it is. Oh, good. Yeah. Yeah. Because it's the whole community. And I know you probably have seen in the news that Jimmy Carter's on hospice. Yeah, he went on in February.
For a while.
Yeah, and it's November. So everyone in hospice is going, go Jimmy. Because it's the biggest thing to change people's minds. They're like, oh, it's not just for right at the end. You know, it's great. And he was just, I guess, last month in a parade through Plains. He and Rosalind were, you know, in the peanut parade or something. So it's great because with hospice, you're not, like, if you have home health and Medicare's paying for it, and I don't know all the ins and outs of home health, but you have to be physically at home. You can't go out and go in a parade, right? But if anyone wants to go in a parade. But on hospice, you can go out and live your life as long as you're capable. You can go and do what you always did, but you just are on hospice care. So some of our hospice patients, you would run into them at the grocery store and not even know they're a hospice patient. So that's one
I
thing.
think that is the perception that I've always had, is that once you go to hospice, it's just a matter of days or weeks and possibly months.
Yeah, and we are changing that slowly. Like the more people come on, and the earlier they come on. Like, and I seriously love that Jimmy Carter's on because it actually got to be a paid benefit through Medicare. I think I'm saying that right, when he was president. So it's kind of like a full spectrum. Like he's now taking advantage of it and doing just wonderful things for the whole idea of it. Yeah.
It's an inspiration for sure.
For sure, yeah. He is.
You mentioned,
What's the definition of palliative care?
Good question.
Palliative care is not for, hospice is for end of life, like care and comfort and pain relief. Palliative care, you don't have to be at end of life. Like that's kind of the easiest way to think of it. Like palliative care, you can take advantage of for a while. You can still be pursuing curative treatments, but maybe you have pain and symptom that's kind of pain that needs to be managed outside of that, or comfort. So it is kind of a team, like hospice is. It's not just a medical professional. So it's more a team. They have chaplains, they have social workers, but you don't have to be at end of life. We work, I would say, here's palliative care, right? It's this big, huge thing, and we're maybe a little circle inside that. So it's a lot of palliative care, which is just easing suffering and pain, but it's at end of life when you can't be palliative. Like I said, one of the big differences is you can still be seeking curative, or it's just a temporary setback that you will recover from.
I think there are a lot of misconceptions about it, but ideally palliative care would begin at a diagnosis, no matter what the prognosis or outcome will be.
Right.
And it also, hospice, we think of it as older people, but we did have like I can't ever remember if it was 2-day or 2 week, but an infant on service last year. Yeah, newborn, as well as someone who was 109. And our access nurse always likes to say it was harder to get the 109-year-old approved than it was the infant. Like it's not this range that people are old, they're going on hospice. It really is based on every individual. So, and obviously for the infant, it was just support for the family.
And it allowed the family to take the baby home and have the baby home for actually a couple of months and have time as a family and make family memories that they wouldn't have gotten had the baby stayed in the NICU.
That's awesome. Yeah. So it's just a wide range, and that's why it's kind of hard to. I think that's why people pigeonhole things, like when it's kind of they don't understand it, they think, oh, it's right at end of life, and it's just that, But it's so much more. It's really so much more.
can you clarify something for me? Something you said that you mentioned calling an ambulance. I can't quite put that together with being on hospice care and calling an ambulance. What situation would that be?
Well, it happens a lot.
It does.
Doesn't
And, it can be
Yeah.
something like somebody falls and breaks their hip, right? That, anything that happens, we want them to give us a quick call because we're available 24/7. They will always get a nurse who can help them. If the nurse needs to go out and do a visit, they can. But we want them to call us first just because we pay for all the services. Once they're on hospice, anytime they do anything outside of that benefit, we pay for it. So we don't want them to go to the hospital for something that is not necessary, just if it's something that the patient is going through that is normal. Because like I said, you don't, until you see the stages of someone dying, and everyone dies a little bit differently, even though in the Blue Book she kind of sets out what it typically looks like. There can be different things that might be we could adjust the medication or send someone out and take care of it rather than send them to the hospital, which is so traumatic for anyone, and especially at the, the final few days which is when they're probably going through that. So that's the, and if they definitely need the hospital, we won't say, no, you have to stay home. We obviously will send them to the hospital, but we just want to make sure if it's something we can help them take care of the patient at home, we can do that rather than have to talk to them when they're in the hospital, which sometimes happens because it's people call 911. That's what we're programmed to do when someone's in distress. But distress in hospice doesn't always mean the hospital is the best place to be.
And what looks like distress isn't always distress for the patient.
Yes, that's
I think
a good
that
point.
sometimes, no matter how much information we can provide, it's normal for family members to panic when they see the agonal breathing or secretions and things like that, and maybe it looks uncomfortable, and it makes their loved one look like they're in distress when they're not.
Any other questions?
Any other questions?
I've got one more. I experienced a hospice referral from a hospital to Gosnell House. And it seemed like there was a real communication problem about that referral or that discharge. And what criteria are used at the hospital, for instance, if someone chooses to,
If they need to go to Gosnell.
they need to go to Gosnell?
Usually we work so closely with the hospitals around here. Was it Maid Med? Or
Yes, it was.
yeah, because we work with them. We actually have a training program. Their residents come over and work at hospice, so they're pretty familiar with
It
what.
was 3 years ago, so it may
It
have been
was.
before training. so.
Okay, yeah, or maybe during COVID when things were a little up in the air. But they should know, like, there are really strict criteria on when Medicare will pay for Gosnell, for that acute care. So it seems like maybe there was, sometimes there are a lot of young physicians and residents
Yeah.
that aren't, maybe they haven't gone through training or we shut down training at that point and they don't really know and they think, oh, it's hospice, I'm going to send them there. But really they needed to be home or in a facility because they wouldn't qualify and be able to take advantage of any of their benefits. That's the only thing I can think, not knowing, what specifically happened.
I'm like, the best thing is to call you.
Yes.
With any questions.
Exactly, and
Yeah.
they can refer online. We have this whole list of, is the patient this, is the patient that, just because, like we take patients with, it's, used to, kind of hospice started out mostly with cancer patients, but now it's expanded and we take many people, and dementia is one of the most difficult ones because people can survive for years with dementia, and Medicare says, no, they have to be declining. So there's a fast scale that they have to be 7 or above, and there are all these very specific kind of hoops that the patient has to meet in order to have Medicare pay for their hospice services.
So as a patient advocate would be a family member, they would need to really be staying involved,
Yes.
asking a lot of questions, and also call you.
Exactly. And because those things can change really quickly too sometimes, like the minute a patient stops eating, and has dementia,
No
that's,
meds, no eating.
yeah. So it can happen really
That's where she
quickly.
was.
Yeah.
Thank you.
Well, I just want to vouch that my dad, when he was in the hospital and was deemed he was terminal, he got hospice through you guys, and I think it was 5 months, and they were a godsend. They really were. And during that time, my boyfriend died while Dad was getting hospice, so they reached out and helped me then. And then Dad died, and a year later, my mom died. And she wasn't a patient of yours, but I got a sympathy card and a call.
Oh.
And I still have, for like a year, I got like a monthly,
The newsletter?
the newsletter. I still have those newsletters.
Oh,
Good.
good.
And what to expect, that guidebook, I still have that guidebook. Because I read that
Nice.
when my mom was dying, we brought her home from the hospital on like Friday, and she passed on that Monday. And that guidebook was very helpful, because at the end we knew the breathing. And like I got my daughter and I'm like, I think it's near the end, and it was like an hour. But you know, she's able to be home, which was her dream, to be home, and I had been prepared.
Good.
So, definitely a wonderful organization.
Thank you.
That's great.
Appreciated it.
I just want to say how thankful we are that you came today to share with all of us, and it's just been so informative and so enlightening in so many different ways, and really appreciate you both being here.
Thank you.
I thank you for all you do.
We have an online comment from Bonnie. Thank you for such an informative workshop. My mom passed at the Gosnell House in 2014, and my family was so pleased at not only her care and ease of passing there, but for all of the support you offered all of us.
Thank you for sharing that, Bonnie. That's great.
And I'd like to add that I am a volunteer at Gosnell House.
Oh,
But
fantastic.
I am on sabbatical right now because I've had some stuff going on in my family and had to step back. But it's a great place to volunteer.
Yeah, good. Thank you for doing that.
We are very.
No, I was going to say, and donations are gladly accepted. To see a number of fundraisers that you're doing, but you know, as a nonprofit, I understand you're always
Yes.
always looking for donors. So.
And we are so grateful for our volunteers. I can't even begin to tell you how much our volunteers mean to us and the community as a whole, because the community is so supportive. Yeah, it's wonderful.
Well, let's give them a hand.
Thank you. Don't take those papers.